there is still a risk to applying a therapy. We have this kind of pull from our heart to use all potential treatment options for patients. And I absolutely sympathize with that, particularly when it's a loved one or a patient that I understand that perspective. There also, though, is risks. There's another side of that coin. So if you apply a treatment that has a 5 to 10% response rate, I get the desire not to leave anything on the table when you're trying to handle a situation. But if it has that low response rate, well, then the flip side is, it also has a 90 to 95% chance that it doesn't work. And applying a treatment that doesn't work, the truth is it's worse than doing nothing. The ultimate outcome for the patient is worse than if they pursued hospice care or palliative care in those situations. So what I really try to focus on is a heightened awareness of that and really encouraging us to push to understand how to apply these things to our practice. So this PD-L1 as a biomarker is far more nuanced, I think, than what we're used to with biomarkers. Again, the old biomarkers, HER2 and BRAF and ALK, they've been kind of the point where our expression or where our treatment pathway is kind of bifurcated. Simple binary choice. If you're this, we do this, and if you're not, we don't. PD-L1 expression, utilization of it is going to be much more complicated, but I do think it can help guide treatment choices. I think in melanoma, that's a great scenario. Combination immunotherapy in that setting does have a slight advantage, but the expense of significantly increased toxicity. Another potential example, and this is more abstract, but I think is where we need to push, is where we really try to aim and shape our treatment decisions around the value systems of the patient. So are you the type of patient where at all costs I want to try every possible treatment? Then it makes sense to not really worry so much about what those biomarkers are. On the flip side, there are absolutely patients that may be willing to try a treatment that has a 50% chance of response, 30% chance of response, but they may be absolutely unwilling to try a treatment that has a 5 to 10% chance of response. That may not rise to that threshold that they think, yep, it's worth continuing. Being able to offer that clarity to a patient in our discussions with them as they kind of pursue how do they handle this, unfortunately, likely terminal illness, I think it's a huge benefit to those patients so they make more informed decisions, and that's kind of where we landed on, is the importance of pushing beyond. I think kind of my big take home is that most people, pharmacists in particular, sometimes tend to avoid conflict. I'm absolutely one of those types of people. I avoid conflict. But as unsettling as this is, we have to be willing to pursue that conflict and wrestle with it and figure out how to maybe use this tool. It's challenging. We don't have all the answers, but I think there's something there that we should pursue to try to figure out.